I will start off talking a little bit about labels because I know a lot of people have difficulty with the idea of labels, and I like to sort of get that out of the way to begin with. I've witnessed people, particularly in social media, not wanting to be labeled because of stigma or not believing that these are actually real diagnoses. People fear that a diagnosis of Tourette syndrome, ADHD, etc., will be problematic instead of being helpful, when really it is helpful. And I've experienced that myself. I actually have 3 adult children now who have the label of Tourette syndrome plus, which means they have Tourette syndrome as well as associated disorders such as ADHD and OCD, or obsessive compulsive disorder. And my kids went from behavior problems and kids who were weird or lazy, refusing to do their work at home or at school or in the workplace, to having a direction, giving people a direction and a means to communicate to others about what is happening. And it's meant to build empathy instead of judgment. And I believe we need to use the labels to actually reduce the stigma. So I will be using the terms that are used to diagnose these disorders. And I'm going to talk very briefly about the origins of Tourette syndrome. It's a neurological condition and it's characterized by tics. And it was named after the French physician Gilles de la Tourette. And he published an account in 1885 of 9 patients with what he called convulsive tic disorders. And just know it is a brain-based or a neurodevelopment disorder characterized by tics. And what are tics? Well, they're a voluntary capitulation to an irresistible urge. It's not easy to resist the urge, especially for young children. As people grow up, it becomes somewhat easier, though it depends on the severity of the tics. And there's often no reason to resist a tic, and it becomes very automatic. Think about scratching an itch like a mosquito bite. The itchy feeling is not voluntary, but the decision to scratch it is. And we can hold it back for a while, but sometimes we just scratch and we do it. So that's what a tic is like. Now they're described as semi-voluntary or involuntary because they're not strictly involuntary. They may be experienced as a voluntary response to the unwanted I can't speak tonight, premonitory urge. And it's a unique aspect of a tic, and it's relative to other movement disorders, is that they are suppressible yet irresistible, like I was talking about with the itch. And one thing that's really important is they're constantly changing. How they appear or how they sound, they're often repetitive, and they are very different from one person to the next. I said I have 3 kids who have the symptoms of Tourette syndrome and have been diagnosed with Tourette syndrome. All 3 of them are very different from one another. They tend to wax and wane. They come and go in both number and frequency, in complexity and severity, and between people. So they can, there were times when my kids had very few tics and other times where they had a lot. And this can wax and wane constantly as they grow up, and even into adulthood, they can keep changing. And they have to have 2 parts to be called Tourette syndrome. They need to have a motor tic. They actually have to have 2 motor tics and a vocal tic or a sound. And I'll get into what those are momentarily. So the simple motor tics are usually less than a second in duration. They're very quick, and they usually involve one muscle group. Some examples would be like blinking quickly or opening your mouth very quickly. And the movements are really rapid and they're meaningless. They're not done to sort of get something out of your eye or to, clear your throat or something like that. They just happen very, very quickly and very suddenly, such as nose wrinkling, shrugging. I've actually talked about eye blinking as well, but it could also be jaw snapping, arm or leg jerks, head jerks, kicking, finger movements, toe movements, a wide range of movements. Essentially, any movement that we can do can become a tic. Now, a complex motor tic, that's when it involves multiple muscle groups and can be slower or more purposeful in their appearance. And they're rarely seen without the simple motor tics. For example, We could have somebody who has, they blink, then they shrug, and then they open their mouth. So they have a bunch of tics all in a row. They can have gyrating and bending. I knew somebody who did constant squats as they were walking. You can see it could be quite uncomfortable. Evening up is a big thing that also goes into some obsessive compulsive disorder, which Julian will talk about later. Now, the motor tics can also look really purposeful. Now, these are some of the more complex ones. Palapraxia, that's a repetitive complex movement where they do it over and over and over again. Echopraxia, this is the one that can look like mocking. It's copying the actions of others and they can't help it. So somebody might be jumping or doing a dance and they'll try to copy it because their brain is telling them to do so. And copopraxia is a motor obscenities, which such as giving the finger or grabbing genitals. And we'll see some more of that in a little bit. Now, simple vocal tics, we're going to move it from the motor into the vocal tics. And these usually appear after the motor tics emerge in childhood. And they're essentially sounds. And it can be any noise, any sound, and that could be potentially become a tic, including things like sniffing or throat clearing and coughing, barking like a dog, including spitting, sucking, screeching, gurgling. It is endless. Hissing, any kind of sound that can come from the mouth is considered a simple vocal tic. But then we get into the complex vocal tics, and these can be whole words and phrases or statements. And more importantly, it's out of context speech. So it can sound intentional, it can sound maybe even angry, but it really isn't. Shut up. Such as if I did that, right? Shut up. You're fat. Right in the middle of a sentence, it's out of context, but you can see it's sudden and sharp. And my kids actually did the I love chocolate milk. They would run up to their friends, and the first thing they would say, I love chocolate milk, before they would start to interact with their peers. What's for dinner tonight? My oldest son, he said that first thing in the morning, after school, during dinner, and after dinner. And what was really interesting with that one, it was really context specific. So he only did that tic with me. He didn't do it with anybody else. So they can be specific to location or person as well, but very out of context. They change in volume, pitch, or the rate of speech. It can be affected. Stuttering is a symptom of Tourette syndrome, but just recognize that stuttering does not mean you have Tourette syndrome. So you can stutter without having that diagnosis, but it can also be a symptom of Tourette syndrome. Now, this is what I was talking about earlier with the copopraxia. So this is something that unfortunately is portrayed on TV shows like with Dr. Phil or Oprah Winfrey in the past, as well as on TikTok videos. A lot of social media really show people with Tourette syndrome swearing all the time. But the number of people, or the percentage of people at any time that have Tourette syndrome that swear, is less than 10%. The range is usually given as between 7 and 10%. And it's probably the biggest misconception around Tourette syndrome. And don't forget, I talked about how they come and go. They're constantly changing. So somebody with the swearing tic may not have the swearing tic later on. And these ones also are ones that can really cause some problems. Like, people can misunderstand that this is disrespectful behavior in the workplace or the school, wherever it may be, or mocking when it's really not, such as repeating your own words, and more specifically, echoing others. Kind of like the behavior with the movement one, where they're copying the movements of other people. This is actually repeating back, and it may be slightly different. For example, we're in a meeting, everyone get your pencils out. Everyone get your pencils out now. That kind of behavior might add a couple words or take out a couple words, but it's really not mocking. It can be part of the disorder. And you should be aware that a lot of these tics can become harmful. And people often don't think about that. They think it's more just something that's inconvenient. For example, if somebody has an eye rolling tic, it can cause headaches. And grimacing can cause neck and back pain. Biting the lips, arms, fingers, or other objects can cause tooth and jaw pain and damage, of course, the skin. It's often biting the lips can become a tic, and that's not good, especially if they start bleeding. Jaw snapping, hyperextending beyond normal range. I've heard of somebody actually snapping their jaw so severely it dislocated their jaw. And things like rapid head twisting and jerking can cause neck pain. And then we get into some of the more serious ones, such as slapping or punching yourself with a lot of force, hitting yourself with utensils or a TV remote. I actually have an adult friend who did this, and touching and handling dangerous objects such as matches and razor blades, knives. We have to be really careful. I know of another adult who did burn himself with cigarettes. He was a smoker, and he would burn himself as a result of his tics. Oh, excuse, my dog says hi. Now, here are some things that make the symptoms worse. Listen, things that make things worse: anxiety, and I'm talking about good stress and bad stress. So excitement over a holiday, or there's a deadline coming. The tics can get worse in those situations. Also fatigue, so if you're not getting enough sleep, and illness. So before an illness happens, the tics could be under control, you get sick, and it can actually produce tics. So people who get a cold, they cough, the cold goes away, the cough goes away. But someone with Tourette syndrome can maintain that cough and keep coughing for months afterwards. So the illness can actually make the symptoms worse. And I think the other thing is sleep challenges. You can imagine it can be difficult to go to sleep. You're not sleeping well, and then your tics get worse. It's like a vicious cycle. So another one that's really important is actually seeing or hearing someone talking about ticking can actually make the tics worse. My kids if I said to them, hey, you haven't seen that tic for a long time, they'd say, stop it, Mom, I don't want to hear about it because I'm afraid it will come back, because it can. And my friend Steve Call he's the adult I've been talking about. He went to a conference and someone was saying monkey repeatedly, and it made him want to start saying monkey repeatedly. So it can be an issue talking about the tics and hearing or seeing somebody else tic. What can help? Well, this is kind of like what I was saying, getting a good night's sleep. That can be hard. Exercise, just like everybody. And activities that require focused attention, something they love. So if they're really into something at work or at home, the tics can diminish and go completely away. So one of the things that makes people feel like we can say, just stop ticking, just stop now, is that periodic suppression is possible. However, it takes intense concentration. Think about that mosquito bite I was talking about earlier. If I said to you, okay, you're not allowed to scratch, but you have to continue your work, it might be really distracting and all you think about is not scratching. Or holding in a sneeze is another one. Some people can hold sneezes in, but it takes a lot of concentration. And it really will divert attention from the task at hand. And I just want to quickly go over what Tourette syndrome is not. It's not the only tic disorder. There are other tic disorders. It's also not a learned behavior. It's not always severe, and it waxes and wanes, and it's different between different people. And it's not an intentional choice. They're not trying to seek attention, and it is not curable, unfortunately. So what is the occurrence of Tourette syndrome? Well, in 1971, this is Oliver Sacks. He's written many books, and one of his books called The Man Who Mistook His Wife for a Hat, he talks about his very first patient in 1971 who had Tourette syndrome, and he says it was 1 in a million. However, he went out in the street and saw that other people were ticking, so he really didn't think this number was correct. And today's numbers are approximately 1% of school children. Now, as we go into adulthood, about a third get better, and about a third stay the same as they were. and about a third get worse. And my friend Steve is one of the people who, as he aged, his symptoms got worse. And it's 3 times more likely in boys or men than girls or women, and both have the same symptoms. Now, what's the diagnostic process? It's really important that there's more than one motor tic and at least one vocal tic, and they have to wax and wane, like I talked about, but they have to have persisted for more than a year. As I say, people can get tics just for short periods of time, and that's not unusual. The onset of symptoms before the age of 18, and the symptoms are not due to a medical condition or substance. So we don't want brain trauma, say from a car accident, Parkinson's, Huntington's, etc. Now, treatment options, there are pharmacological interventions, and there are also cognitive behavioral interventions such as CBIT, which is cognitive behavioral intervention for tics, and the ERP, exposure and response, and CBT, I believe Julian will talk to a little bit more later on. And most people, youth and adults, diagnosed with Tourette syndrome do have associated disorders. And here's just a really quick look. And I said earlier that my kids had TS plus or Tourette syndrome plus. This is the plus part. So most people do have at least one of these other ones, the most common being attention deficit hyperactivity disorder, or ADHD, and obsessive compulsive disorder, or obsessive compulsive behaviors. Now, the impacts of tics on work. So eye, head, neck tics can make reading really difficult. So it can take a long time for somebody to get their reading done if there's just a lot of reading with the job. And vocal tics can be problematic in a shared work area, especially if they're really, really high-pitched and really loud and really sudden, or if they have slamming. I had a student, actually, I was a teacher, who had a slamming tic and would slam his hand on the desktop. And that can be quite frightening. And we'll talk more to that in a little bit. There's also, of course, hand-arm body tics can make handwriting and typing difficult, but handwriting particularly, it's really good that we have computers and we can even do text, speech to text, etc. So those types of things can be really helpful. So people who have Tourette syndrome plus really do have difficulty with planning, organizing, strategizing, paying attention to and recalling details, time management. Essentially, they're executive function deficits. And they can be really distressing because they are capable people, but they can't produce the type of quality work that they really want to. And that's why strategies and strategizing is so important. And the first one I want to talk about is ignoring tics. I talked about how in the workplace, if they have, some vocal tics, they might be disruptive in a common area. However, if we ignore the tics and the people in the workplace are actually aware of the disorder, it becomes more like a cough or a sneeze. Nobody thinks twice about anybody suddenly sneezing or suddenly coughing in a workplace. And it will turn into that. Now, it would have to depend on the tic, and it would depend on the worker as well. They may choose to maybe leave if their tics are particularly bad. So having that kind of workplace area that's safe for them to go. So, and just let the person know they don't have to hide their symptoms. I think that's really important. And when they don't have to hide it, anxiety goes down and their tics can get better. So as I said, allow a safe place to work. So talk with the person. They might have their own office or they share a room, but have a place to go when they need to. It needs to, there needs to be a place that they can comfortably tic. And with regards to instructions or emails, etc., bullets help everybody, not just people with Tourette syndrome, but bullets just make it easier to read, and then you can check things off as they need to be done. So this is a really good advice just in general. Just bullets are easier to read in an email or any other type of instruction. And there's a lot of apps out there, and this is just two. There's so many. It's hard to even pull them all out, that they can help to stay on task. The simple timer is one where it just gives an audible cue on regular or irregular basis, depending on what you want. Some people find irregular cues are better because then that cue goes off. Am I on task? Am I focused? And it's just a little check-in for the person. And also something called the mindfulness bell does a very similar thing. But of course, calendars, though it can be challenging for a person with Tourette syndrome plus to remember to add things to their calendar, so that can be a challenge. So reminders, etc., group calendars can be helpful. And again, recognize that every person with Tourette syndrome is different. If you know one person that had the disorder and you meet another person 5 years later, recognize that their tics may be different, their difficulties may be different. Don't assume if you know one person that everybody is the same and you'll have the same success or failure. So just remember that. And just to very, very briefly, I like to go over a little bit of a history of the development curve of Tourette syndrome. So what this is from the book Tourette Syndrome by Davida Martino and James Leckman. And if you notice, there's a dotted line, so that's when the symptoms start, and then the solid line is when they're there pretty solidly, so not intermittently anymore. So you start here. The first thing that usually shows up is attention deficit hyperactivity disorder. If they get that, the next thing are your eyes and face, and then it starts working its way down through the neck, the arms, the trunk, and then it goes up to the vocal tics are the next things that start appearing, and lastly, obsessive compulsive disorder. Now, I left out sensory because that's a whole other topic, but obsessive compulsive disorder is usually the last thing that starts to show up when there's a person with Tourette syndrome. And that leads me nicely into Julian's section.
Wonderful. If you unshare yourself, I
Thank
will
you.
do what I need to do. So,
And if you need me to edit the video, like where my dog was barking in this part,
that's okay.
I can do that really easily if you want to send it to me.
Can you see that okay? Can you see my slide? Oh, I'm not. I'm
Sorry, I was
muted.
muted. Yes, I
Oh, you're
can.
muted. Thought I was muted.
No, I was muted.
Wonderful. Okay, I'm just going to move you guys up there so I can see this. Okay, so good evening. It's a pleasure to be presenting this evening, especially alongside Adrienne. I am the program coordinator of the Tourette OCD Alberta Network, and we are indeed based at the University of Calgary. We're a not-for-profit organisation based at the University of Calgary. Just to give you some background, I attend the Pediatric Tourette Clinic at the South Health Campus weekly, sometimes twice a week, and provide psycho education to patients and families who had a recent diagnosis of Tourette syndrome or tic disorder and or OCD. And I also generally weekly attend the pediatric OCD program at the Richmond Road Clinic in Calgary, again to provide psychoeducation and resources. So I will be speaking to you about obsessive compulsive disorder in relation to adults in the workplace. So I will just generally give you, and many people know about OCD, so I'll just give you a brief overview. And there are two components to OCD, obsessions and compulsions. And as I said, you're probably familiar with these, but I will just provide the overview. Okay, so OCD in the workplace, as it can be anywhere, can look like someone is perhaps inattentive or even apathetic, when in fact the person might not be completing the work task for the fact they may be having overwhelming thoughts, and they are just so overwhelming that they're having difficulty coping in that moment, and they might also be hidden to management and work colleagues. And the other thing is to say that the person suffering from OCD, or has OCD, generally knows they're being irrational, so will go to quite some lengths to hide their thoughts. So obsessions are repeated and persistent thoughts, urges or images that are intrusive, meaning they come crashing into your mind, unwanted and repetitive, and they range in type and are very difficult to control. So obsessions are the first component of obsessive compulsive disorder. And they manifest as recurrent and persistent thoughts, urges, or images that are, as I said, intrusive and unwanted and repetitive. And they range in frequency and nature. And again, are very difficult to control. And they are marked by, of course, acute anxiety and distress. And obsessions can range from the offensive to the very intrusive. An example being, is my door unlocked, or thoughts that may be violent or sexual in nature. So these are some examples of obsessions. Some of the most well-known ones: magical thoughts, superstitious obsessions, contamination obsessions, religious obsessions. There are many more. They're very wide-ranging. This is just a small sample. There may be kind of fear of harm coming to the individual, or more often their family. As I said, unwanted sexual thoughts and general doubts, perhaps about relationships, and perfectionism. So compulsions. The second part of OCD is the compulsions, which are repetitive, deliberate actions or mental acts. And compulsions are performed to relieve the anxiety related to obsessive thoughts, or to prevent some negative outcome from occurring. It is an attempt to neutralize the overwhelming and uncontrollable thoughts. So remember, the compulsions, like hand washing, may not be connected in a realistic way to what they're trying to neutralize. But they are efficacious in that the compulsions provide relief, but only temporarily, until the next intrusive thought comes along and the cycle begins again. Okay, so the person with OCD knows that perhaps touching a certain object 20 times or washing their hands incessantly will not protect their house from a tornado or an earthquake. And if they don't do it, that something bad will happen. But the thoughts and compulsions won't stop. And individuals with OCD can feel like they're going crazy. And they will go to great lengths to hide their behaviors and thoughts from their family members and work colleagues. So, of course, that has a bearing on how we help that individual in a workplace scenario if, as their colleagues, we don't understand what it is that the condition that they have. So it's really complex. So an employee may have a compulsion to count to 20 after reading every 6th word in a document, because if they don't, they think harm will come to their family. And they may even believe that their family is going to die. On the outside, this might be perceived as kind of laziness or incompetence, or that's the perception. And as it's hidden, it's obviously quite complex. So some examples of compulsions. We have washing, and the cleaning of hands. And I've seen that. I do sometimes attend the adult clinic too, at the foothills. And they take that further. Their hands can be quite red raw, and in some cases bleeding. And because they've been doing it for such a long time, sometimes hours. And I've seen, through being in the clinic with the clinicians, is that they often refer to as OCD being a disorder, or obsessive compulsive symptoms become a disorder and becoming clinically significant when the compulsions get in the way. And generally that is if compulsions are take longer than an hour in someone's day. So, an hour does seem quite a lot, but I've seen many patients who will perhaps have a cleaning compulsion or will be showering for hours on end. Of course, there's an issue there. So if the compulsion, if the ritual is lasting longer than an hour, then perhaps we have a disorder, and it's time to consult a doctor. And again, lots of people do say, oh, I think I'm OCD. We can't say that. We can't diagnose ourselves. It does need to be diagnosed by a doctor. So another one is checking if working with another colleague, let's say on a report, and an individual asks their colleagues or manager repeatedly about the report. For example, how long should the report be? When is the deadline? Or when will my colleague finish their part? Will the report be checked? Will there be an overview by another colleague before submission? These sorts of questions, so on and so forth. Could be that a person speaking in this manner is speaking through their compulsions. Counting compulsions are significant. Someone may count in things in 3s or 7s and will feel uncomfortable often if numbers are disordered. They may want to carry out tasks 3, 7, 8 times, whatever is the significant number for them. And it may be entering a room that many times or sharpening a pencil. Excuse me while I just have some water. So, there's also ordering and arranging and that kind of symmetry and evening up that, this is quite common that Adrienne mentioned before. The kind of evening up is quite different with someone with OCD. Let's say we think about the classic one is on the shoulder. If they have Tourette syndrome, they touch themselves on one shoulder and it just doesn't feel quite right, and it only feels quite right if they touch themselves on the other shoulder. But with someone with OCD, they may believe if they don't touch the other shoulder, harm will come to their family. So that evening up is really quite different in terms of what it means to that individual, and the fear that engenders for them. And it's the thought that something is not right, that something is incomplete, and therefore symmetry and order must be achieved. And it's something that the person can get quite stuck in. So they may be doing a work task, working with others, and they're stuck in that task because they're trying to find some sort of order and symmetry. Okay, I just want to talk about obsessive compulsive personality disorder, because I was talking to some psychiatrist friends or colleagues, sorry, and I would be doing this webinar soon, and they had mentioned that, and quite a lot of adults actually have OCPD rather than OCD. So it's different from OCD in that there is early adult onset. And as Adrienne was saying before, often around about the age of 10 or 11, OCD starts in childhood. With OCPD, it's quite different. And adults may think they have OCD or obsessive compulsive symptoms when they may have OCPD. Now, OCPD in the DSM-5, which is the main guide for mental health providers in the US, has traditionally been characterized as an excessive preoccupation with orderliness, mental and interpersonal control, and perfectionism at the expense of efficiency, openness, and flexibility. And it would seem that the compulsion, or the need to do a compulsion, is often not present with someone who has OCPD. So the main differences between OCD and OCPD is insight. And as I said before, with OCD, the individual is cognizant, is aware of the irrationality of their thoughts, and has good insight into it, and is distressed by the symptoms, whereas someone with OCPD lacks insight, believing that their way of thinking and doing things is correct. And I'll say a little bit more about that as we go through, because you can imagine the kind of stress that causes for colleagues in a work situation. So functionality and impact, OCD causes significant distress and impairment in the daily life. Individuals often want to get rid of their symptoms. With OCPD, it may cause interpersonal or occupational issues, but is often less obviously distressing to the person themselves. So quite a clear distinction there as we go through these. Onset and course, OCD often begins in adolescence or early adulthood and can fluctuate over time, as I said before, whereas OCPD begins in early adulthood and remains relatively stable over time. So examples of OCPD, perfectionism, an example there, John spends hours formatting report to be just right, so that we have that just right phenomenon again, and misses deadline. He doesn't see this as a problem. He believes others are just careless. So again, we could conceive of a situation, an intractable situation at work where someone is unable to see that their behavior is causing a problem. And if we look at rigid moral standards, Sandra refuses to delegate tasks at work because no one does it correctly. She believes her standards are reasonable, though co-workers find her inflexible and difficult. So again, this rigidity is, or someone with that species of rigidity is really quite difficult to work with. And if we don't know that they have these traits within the disorder that they have, it's really quite difficult to work with them. So it's that knowledge, and the psychoeducation is really important. Okay, so real life examples of OCD versus OCPD. OCD washes hands 40 times a day due to fear of germs, knows is excessive. OCPD spends hours on a report for perfection, sees it as necessary, lacking that insight again, which I'm sure could create a lot of tension in the office and ill feeling. Repeatedly checks, and OCD repeatedly checks locks, stove due to fear of harm. OCPD can't delegate tasks, insists on only their way is correct. Implications for working in a team there, in a workplace scenario. OCD rituals cause distress and interfere with daily life. OCPD rigid standards cause conflict, but person sees them as right. So we have a kind of like a wound there, perpetual conflict, unless that person who has this behavior is able to have some counseling to enable them to operate in a workplace situation. But it's that intractability that obviously becomes a source of stress and friction in the workplace. So how OCD presents in the workplace. Okay, so again, we have repeated checking behaviors, again, repeatedly checking if emails were sent, attachments were included, or files were saved correctly, even after confirming. Again, that will cause a lot of time wasting, certainly decrease productivity or delay productivity, and of course, it is a source of anxiety, which will have an impact in the office, if that's where they work. And fear of making mistakes, excessively reviewing work due for fears or errors or being criticized. Now, this is often seen in the classroom too, and that naturally translates to the work environment. And again, perfectionist tendencies that go beyond normal standards may lead to burnout. So perhaps we have a person who's perhaps not making rational decisions due to a perceived defensiveness and fatigue. Okay, so a few more here. Obsessions about contamination, avoiding touching doorknobs, using others' phones, computers, or attending meetings due to fear of germs. It goes without saying sorts of impact that would have and the problems that could entail. It may lead to isolation or difficulty collaborating with others. So working in a team, if they're working in a team, becomes difficult. Mental compulsions or rumination, constant internal reviewing of conversations or interactions to ensure nothing wrong was said. Impact, distraction tasks, stress increases, and of course, performance decreases. And of course, that has ramifications for the person's situation in the workplace if their performance is declining. Okay. And time-consuming rituals, having to perform a task in a very specific order or repeating actions like typing or organizing to feel right. The just right phenomenon again comes to the fore. Efficiency is decreased and deadlines will be missed. Again, ramifications for the office and a team if the person is working in one. Avoiding specific tasks, people or situations that trigger obsessions, avoiding writing reports due to fear of errors. And it does, limit the scope of work for this person, job responsibilities, and again, performance is impacted. Water. So what can help? And often I think it sounds like we're stating the obvious in terms of support. But there are difficulties for management of the individual if the individual goes to great lengths to hide their OCD. But, I know of companies that my family has worked in where there have been great management support, certainly with mental health awareness, but it is the very least we should expect. Clear communications, expectations, and structured feedback, very important. But with regard to that, it is vital because people with OCD, if we set expectations and they're not met, they're going to be crushed and crestfallen. And there'll be this overwhelming, this increased sense of failure. And so this has to be managed. So again, management needs the requisite skills and knowledge to manage someone in that situation, because setting expectations again has other issues associated with it with a person with OCD. Flexible deadlines when possible. They can be easily modified. No flexibility in modifying work tasks don't mean that they're doing anything that's easier necessarily, but it allows for a person to complete work and tasks and feel satisfaction and achievement, which builds confidence and accomplishment, and it makes them part of a cog within the team and within an organization. So that modification is necessary. Encouraging professional help, CBT, that would be wonderful if management were in a position to do that. Sorry, it's gone the wrong way. And accommodations under workplace mental health policies. In the workplace, that may constitute time out, perhaps, a slight pause when anxiety is heightened, when the individual feels that they need just a break. Again, it's not going to be for a long time, but just to let them perhaps just reduce their levels of anxiety. So creating an inclusive culture, training, really important. Educating staff on neurodiversity and invisible disabilities. Inviting us, absolutely, to their workplace. Not enough organizations do that. In fact, almost none do that. We would love to do so many more. That's a great place to start, and it allows the staff to have that psychoeducation about certainly Tourette's and OCD, which is absolutely vital. And certainly there are other comorbidities that they really need to know about too. Communication, that's key wherever we are in any organization. It's certainly at the heart of trying to support someone who is neurodiverse. Encourage open and respectful dialogue. Again, we would hope that would always happen. I'm sure it doesn't always happen. Support, offer employee assistance programs like EAPs and peer support groups. Now, EAPs is an employment assistance program, is a confidential benefit program offered by employers to help employees and their families address a variety of personal and work-related concerns. EAPs provide access to mental health professionals for short-term counselling, support and resources. And again, I know through family experience that certainly is on offer quite a few organisations. Again, just an overview again, challenges to look out for in the workplace for OCD, time-consuming rituals, anxiety and perfectionism, and difficulties with change in routine or uncertainty, because that is something else that is quite pertinent to people with OCD, if they don't have some warning about a routine change, it can be quite impactful and certainly create uncertainty. And those are things that can certainly impact the workplace negatively. Legal protections. Canada protected under the Canadian Human Rights Act and Provincial Human Rights Code. In Alberta, human rights are protected by the Alberta Human Rights Act, and again outlines there how the Act prohibits discrimination based on various protected grounds, and one of them is disability, mental and physical. Sorry, I can't quite read that because that's in the way. Employees provide reasonable accommodations and prevent discrimination. Provincial and territorial human rights codes. These codes require employers to accommodate employees with disabilities, including neurodiverse individuals, unless doing so would cause undue hardships. This legal obligation ensures that neurodiverse employees have the support they need to perform their job duties. So, this is enshrined in law, in human rights codes, and it's a fundamental right that everyone has in the workplace. Just want to go over some video and recordings. These the two organizations here, the Tourette OCD Alberta Network and the International OCD Foundation, both have a large a large collection of education webinars and videos available. There's a QR code there, and again, this is another juncture for me to provide an overview of what is available through our organization. There's a whole gamut of resources that would be very useful for anyone working in the workplace or wanting to know more about OCD and how it affects people generally and when they're working with others. And I also just want to say a little bit, I know Adrienne did mention it, but I didn't have to do a particular slide on it with regards to treatment for OCD. Now, I did read recently in one of the clinics I was at that it takes on average between 7 and 12 years to get the right treatment, the right mix of treatment for someone with CBT. With OCD. And there was a POT study some time ago that provided an overview of the ideal treatment for someone with OCD, and it was a mix of cognitive behavioral therapy and medications. It was proven to be much more efficacious than either not any treatment or just having medication or having CBT on its own. So a combination of the two, it would seem through that study, the best way to have for a person with CBT. Sorry, get my words mixed up. A person with OCD to move forward with the difficulties of the condition. So again, this is who we are, the Tourette OCD Alberta Network, which is a little bit covered there for me. Our mission is to improve access to care for people with Tourette syndrome and obsessive compulsive disorder province-wide. And you can go to our website again there, where there is a whole wealth of resources available. And there is also ways that you can contact us, contact me. We're available for in-service workplace presentations and certainly in schools as well. And certainly as to help and guide anybody who needs help in understanding Tourette syndrome and OCD. And at that point, I will stop the presentation.